Good afternoon, and welcome to the National Society of Genetic Counselors webinar series. We're excited to start a new format for our webinar series this year and have an awesome presentation to get us kicked off. The presentation today is entitled 1,000 Mosaic Embryos and More, Status Update on PGT-A Intermediate Copy Number. And our speaker today is Andrea Besser. Just a few housekeeping items. We encourage you to ask your questions throughout the presentation using the Q&A feature. We will be monitoring the Q&A feature and we'll leave time for questions at the end of the presentation. You all are automatically muted, so you won't be able to ask your question via voice, but if you can throw it in the Q&A when you think of it, we'll definitely come back around at the end and go through the questions. Learning objectives for today's webinar are describe how embryonic mosaicism is inferred via preimplantation genetic testing for aneuploidy, or PGTA, and recognize the limitations of this diagnosis. Learning objective number 2 is differentiate between the significance of mosaic results identified in the preimplantation embryo from those identified in the prenatal and postnatal period. And number 3, examine current data surrounding outcomes of mosaic embryo transfers. We're pleased to have with us today Andrea Besser, who is the Director of Reproductive Genetics at the NYU Langone Fertility Center. She obtained her master's in genetic counseling at Mount Sinai School of Medicine and has been specializing in assisted reproductive technologies for the last 12 years. She is a past chair of the NSGC ART and Fertility SIG, and an active member of the American Society for Reproductive Medicine's Genetic Counseling Professional Group and Patient Education Committee. She has co-authored several publications about preimplantation genetic testing, including the ASRM Committee Opinion on Embryonic Mosaicism. We're so excited to have you speak with us today, Andrea. Thank you for joining us.
Thank you, Jessica. I'm just going to share my screen. How's that? Is that working?
You are good to go.
Okay, perfect. Hi, everyone. Thanks for attending this webinar. And thanks to NSGC and the webinar subcommittee and ArtSig for organizing it. So as mentioned, I'm currently positioned full-time within an IVF clinic where I was actually hired just over 6 years ago, primarily because the clinic was trying to figure out how to best manage mosaic PGT-A results. And we've definitely learned quite a bit in the past few years. So the goal of this webinar is to share some of the newer literature and just overall where we currently stand with embryo mosaicism. I don't have any disclosures. So I want to start off with just a little bit of background about the purpose of PGTA and why it has become relatively routine within IVF clinics. Before PGTA, the only way to really select embryos for transfer was based on their morphology or what they physically looked like. But selecting embryos based on morphology alone has really shown to have pretty poor efficiency. The blue bars here are showing implantation rates per transferred embryo, which is declining with oocyte age. And the red bars are showing miscarriage rates increasing with oocyte age. Even among the youngest age groups, fewer than half of the embryos that are transferred tend to be successful. And at older age groups, you can see that the implantation rate is very low and the miscarriage rate is very high. And the main reason for that is aneuploidy. Even in younger age groups, it's estimated that about 1/3 of embryos are aneuploid. By age 40, we start to see that euploid embryos are much less common. And by the mid-40s, they become extremely rare. So it only makes sense that by testing for aneuploidies and only transferring embryos that are deemed euploid, we now see the same ongoing pregnancy rate across all age groups. So those are the purple bars there are showing PGTA. And since most miscarriages are caused by aneuploidy, minimizing aneuploid embryo transfers also results in seeing the same miscarriage rates across age groups. So while we definitely see different chances of finding a euploid embryo based on age, once we have that euploid embryo, age is no longer a factor. Also, PGTA minimizes the number of embryos that need to be transferred to achieve a pregnancy. So while it's common practice to transfer more untested embryos when the age of the egg is more advanced, this study here from 2013, it showed that a single euploid embryo is equally effective as 2 untested embryos, but the multiple gestation rate is much lower. So now it's recommended that if PGTA is being done and euploids are being transferred, that only a single euploid embryo needs to be transferred, and we can minimize the multiple gestation rate that way. So PGTA has evolved quite a bit since its inception in the early 90s, when we could only test for a handful of chromosomes by FISH. And then there was the first 24 chromosome screening that emerged around 2010. A few years later, it shifted towards next generation sequencing, which is the most common way that PGTA is practiced today. There's also been a shift in biopsy technique. So for many years, embryos were tested at the day 3 cleavage stage when only a single cell could be biopsied, or occasionally even earlier, we tested the polar bodies for oocyte-related aneuploidies. But now that's largely shifted towards the Blastocyst stage trophectoderm biopsy, where we can test multiple cells at the same time. And trophectoderm biopsy is really the main way, or the only way for the most part, that PGTA is practiced today in the US. So because of this shift towards analyzing multiple cells and increased test sensitivity, we've seen that the type of results that we get have evolved from these kind of binary euploid aneuploid results to more of a gradient, with the emergence of this middle category of mosaic or segmental aneuploid. And I'm really going to be focusing mainly on mosaic results today. So it's not news that embryos can be mosaic. This was first described by Joy Delhunty in the early 90s by biopsying more than one blastomere on day 3 and seeing differences in sex chromosome ploidy by FISH. And it's really the reason why patients who receive euploid PGTA results are counseled that these results aren't 100% accurate, and why guidelines still recommend that patients who conceive after PGTA should still be offered prenatal screening and prenatal diagnosis just like any other patient. And we do see that aneuploid pregnancies resulting from the transfer of embryos diagnosed as euploid. Our group found that this happens about 1% of the time with NGS that we can detect. So these are cases where POCs had been tested, or CVS or amnio found discrepancies from euploid embryos. But the reason that mosaicism has really come to the forefront of PGTA discussions in the past few years is because of its increased detection through trophectoderm biopsy and NGS. And it's really the detection of mosaicism that has raised several questions about how to interpret these results and how to best counsel patients on how they can use this type of information. So I've broken this down into 4 main questions, which we'll address. First question is, how often does a mosaic result truly indicate mosaicism? The second question is, how often does a mosaic biopsy represent the rest of the embryo? Third question, how does a mosaic result predict the embryo's reproductive potential? And last question, what's the clinical impact of a mosaic result on an ongoing pregnancy? So starting with the first question, how often does a mosaic result truly indicate mosaicism? So the way that mosaicism is usually defined is 2 or more cell lines with different chromosome compositions in the same embryo. So understandably, this is sort of what patients and their providers are tending to picture, getting some normal cells and some abnormal cells on the same embryo biopsy. But we have to remember that's not the case when we're biopsying embryos. The cells aren't actually being tested individually. What we're testing is a clump of cells that get put into this PCR tube. Those cells are going to be lysed immediately. So there's no way to actually determine results for individual cells. We're not actually seeing a mix of normal and abnormal cells. So it's not quite an accurate description. We're also not karyotyping these samples. They're being assessed for copy number through NGS. So here we have the profile of an embryo biopsy. The x-axis of the plot shows all the chromosome numbers, 1 through 22, X and Y. And then the y-axis is showing copy number, with the bottom line being 1 copy or monosomy, middle line is 2 copies or disomy, and top line is 3 copies or trisomy. So here we're seeing disomic results for chromosomes 1 through 6. But then at chromosome 7, we see that there's a trisomy. At chromosome 12, we can see that the data points are falling somewhere in between disomy and trisomy. So that's what's being called mosaic. In this case, this is a mosaic trisomy, or if it were between the disomy and monosomy lines, it would be called a mosaic monosomy. So PGTA overall can't directly detect mosaicism. What it's detecting is this intermediate copy number. So the question really becomes, how often does an intermediate copy number represent mosaicism? Well, the way that these results have been validated is using these dilution or these mixing experiments, where they take known euploid and known aneuploid cell lines and mix them together in different ratios, and then look at the copy number output. So when all of the cells are disomic for a given chromosome, the copy number should be 2. If all of the cells are trisomic, then the copy number should be 3. Or if there's a mix, then the copy number would fall somewhere in between 2 and 3. So these types of studies are used to validate the detection of mosaicism, meaning that if the biopsy truly is mosaic, it often can be detected as an intermediate copy number. But that doesn't automatically mean that an intermediate copy number always means that the sample is mosaic. First, the data itself can vary in how easy it is to read. So whole genome amplification is used by not all, but most labs to perform PGT-A, and that can introduce some noise or some artifact to the sample. So some samples are going to be much cleaner than others, where abnormal copy numbers might be very obvious, but for other samples, noise or artifact or possibly DNA contamination, that's something that could be causing that intermediate copy number and could be mistakenly interpreted as mosaicism. Also, mosaicism calls can vary depending on the thresholds that the PGT lab chooses. So here we can see the same biopsy run on the same platform, but with different threshold settings for euploidy. The top profile has a 20% threshold, and here you can see the data points at chromosome 19 are falling above the disomy range. So this gets called a mosaic trisomy 19. On this other profile, there's a 40% threshold, and now the data points are falling within the disomy range, so this embryo gets called euploid. Same sample, but different calls being made depending on which cutoff is used, and it's up to the lab to make that type of decision. There's obviously pros and cons to using narrower or wider thresholds for calling euploidy. On one hand, the narrower euploid range is going to reduce your false negatives, but on the other hand, it's going to increase your false positives. Or as this paper title describes the two sides of the debate here, are we going for survival of the fittest by eliminating all of the embryos except for the ones with the clearest signs of euploidy? Or are we going for no embryo left behind by trying to minimize the number of embryos that get eliminated by an abnormal call? So as I mentioned, labs can determine which thresholds they want to use to define their euploid or their disomy ranges, but they also make different decisions about what they want to report. This table is showing some differences in how mosaicism is handled by various different PGT labs. Most labs put the onus on the clinic to choose if they want mosaicism reported or not. And if the clinic doesn't want to deal with mosaicism, then the lab decides if they want to classify the embryo that may have an intermediate copy number as either euploid or aneuploid. And that decision can depend on the particular thresholds that the lab has selected, or the lab might have different rules depending on the chromosome number. So as you can see in the right-hand column here, I don't know if you can see my mouse, but in the right-hand column, you can see that these reporting decisions really can affect how likely it is to get a mosaic result, and also how likely it is to get a euploid result, depending on which lab is being used, but also depending on which clinic is being used, in part because clinics can dictate those decisions to the PGT lab. So because of all of these inconsistencies, there's been a push by many in the field to start using less misleading and more accurate terminology when describing these results, and using the term intermediate copy number instead of referring to it as mosaicism, since mosaicism is only one possible explanation for an intermediate copy number. So next, let's look at how well the biopsy represents the rest of the embryo. At the blastocyst stage, when PGT-A is being done, the embryo is made up of two differentiated tissues. There's the inner cell mass, which is going to go on to become the fetus, and there's the trophectoderm, which will go on to become the placenta. When the embryos are tested clinically, it's only a small biopsy of the trophectoderm that's able to be analyzed. So the question is, does that biopsy give us an idea of what's going on in the rest of the embryo, which we don't have the ability to test? And there have been several studies looking at the concordance between that single trophectoderm biopsy that's tested in clinical practice and the rest of the embryo. This is one of the newest papers. This just came out a couple of weeks ago. The investigators looked at 300 embryos that were donated for research with a mix of different results. So some of those embryos had been diagnosed as euploid. Some of them were diagnosed as whole chromosome aneuploid, so a monosomy or trisomy. Some were diagnosed as segmental aneuploid at deletion or duplication, and then there were whole chromosome mosaics and segmental mosaics. They then took 4 more biopsies of each embryo and looked at how those results matched up to the original biopsy. And what they found was that for embryos where the initial biopsy was euploid or whole chromosome aneuploid, so here's the euploids and here's the whole chromosome aneuploids, the concordance rates with other biopsies of the same embryo was extremely high. And that you can see in the very high 90s, at least 97%. But when they looked at the other types of results, here's whole chromosome mosaics, segmental mosaics, and segmental aneuploids, that concordance rate was much, much lower. So one of the conclusions was that a mosaic biopsy result is not highly likely to represent the rest of the embryo. And other concordance studies have largely found that same finding as well. We also have to think about how embryos develop over time, because PGTA just gives us a result at a single time point, somewhere between 5 and 7 days after fertilization when that biopsy is performed. And it's really hard to get a good sense of what's happening between that point and the next time we could test at the time of CVS about 8 weeks later. But there was one study where the investigators were able to culture some embryos until day 12 before rebiopsying them. And what they found was that all the embryos that were originally diagnosed with whole chromosome aneuploidies and all of the embryos originally diagnosed as euploid, they still showed the same results on day 12. However, when they looked at mosaics and segmental aneuploids on day 12, a lot of those were now yielding euploid results. You can see that the sample sizes were very small here because a lot of the embryos didn't survive in culture until day 12, so it was a difficult study to perform. But the results that they were able to get showed that that mosaic and segmental aneuploid results just overall have a much more limited ability to predict the chromosomal composition of embryos at a later developmental stage. So that leads us to the third question. How does a mosaic result predict the embryo's reproductive potential? So before transferring any mosaic embryos into patients, our group looked retrospectively at outcomes that we already had from embryos that had been reported as euploid by array-CGH, which doesn't detect mosaicism. And what we did was we reanalyzed DNA that was remaining from those embryos using NGS. So these are embryos that had already been transferred. We already knew the outcome of them. And now we're reanalyzing the remaining DNA from that biopsy. And what we found was that about 16% of live births were from embryos that today would have been called mosaic. So it became clear that mosaic embryos did have at least some potential, and we'd been transferring them unknowingly for many years. The first reports of babies being born from known mosaic embryo transfers was published in 2015 in the New England Journal of Medicine, where a group in Italy transferred 18 embryos that were diagnosed as mosaic, and they reported on births of 6 babies with normal karyotypes in the chorionic villi. And since then, there have been many more papers that have been published about the outcomes of mosaic embryo transfers. This table is from the joint statement released by the ASRM Genetic Counseling Professional Group and ASRM Practice Committee a couple of years ago. And overall, most of these studies have shown that mosaic embryos appear to have somewhere around a 30 to 35% ongoing pregnancy rate on average, compared to the about 50 to 60% ongoing pregnancy rate that we typically see reported with euploid embryos. The biggest study to date was led by Manuel Viotti and involved 5 clinics, including ours at NYU. And in this study, we compared the outcomes of 1,000 mosaic embryos that were transferred to the outcomes of 5,561 euploids that were transferred. And what we found was that euploid embryos had a significantly higher implantation rate compared to mosaics overall. So here we see in the first bar here, these are euploid embryos. The next bar shows all mosaic embryos, and then the last bar shows only whole chromosome mosaics. So this middle one includes both whole chromosome and segmental mosaics. The last bar is only whole chromosome mosaics. So the difference was even greater when we looked at the difference between whole chromosome mosaics and euploids. And we saw the same pattern with ongoing pregnancy and live birth rates, with mosaic embryos showing a 37% ongoing pregnancy rate, compared to 31% with whole chromosome mosaics, compared to 52% with euploid embryos, and that was significantly different. Also, mosaic embryo transfers led to more miscarriages, more than double compared to euploids. But again, the worst outcomes were from those whole chromosome mosaics. Also, just a side note that outcomes of mosaic embryo transfers were not found to be associated with oocyte age. So next we broke down all of the different types of mosaics. The segmental mosaics performs the best, although still significantly lower than euploids. So this graph here is looking specifically at ongoing pregnancy and live birth rates, and you can see that euploids had the highest pregnancy rates. Next were the segmental mosaics. So again, those deletions and duplications, and those were found to be significantly different from euploids. The low level and high level refers to the percent of mosaicism. So in this study, low level was defined as under 50% aneuploid cells, and high level was over 50%. So the high level, low level segmentals didn't show any difference from each other, but were significantly different from euploid. And then next were the low level full chromosome, either one single chromosome or two, showed again no difference from the segmentals or from each other. But where we did see another difference was when we got to the low level complex mosaics. So those are ones that involved at least 3 chromosomes that had an abnormality. Also in the lower outcome category was the high level mosaics for an entire full chromosome, either 1 or 2, or complex having the lowest pregnancy rates, again, meaning 3 or more chromosome abnormalities. So overall, what we found was that the reproductive potential of mosaic embryos was in part dependent on the specific type of mosaic result, and that mosaics could be ranked or prioritized this way when making embryo transfer decisions. But also what we found was that none of the mosaic types performed as well as euploids. Now, in reality, of course, nothing's ever that simple. And when embryo morphology was added to the equation, there were some scenarios where better morphology mosaics would outperform poorer morphology euploids. Although overall as a group, when we controlled for morphology, the mosaics still performed worse than the euploids as a whole. And we actually had a calculator developed, which is linked in the paper. This was to try to assist with embryo ranking decisions on the basis of both the PGT-A result and the embryo grade, where you can enter both pieces of information for multiple embryos and try to compare and predict which would have a better chance of an ongoing pregnancy. So it generates a score. This is not a pregnancy rate. This is just to compare them to each other. So you can see here, for example, segmental mosaic of higher quality, this 5AB embryo would actually be predicted to have a better chance of resulting in a pregnancy compared to this euploid 3BB, slightly better, just based on the score. The higher score means predicted higher implantation rate, but it doesn't mean an 84% chance of implantation. It's just a kind of arbitrary score. Another landmark study that was just published last year was by Ashley Teagues and colleagues. And this was a non-selection study, meaning that the investigators biopsied embryos before they transferred them, but they didn't analyze the PGT-A results until after the outcome of the embryo transfer was known. And this type of study is very important in assessing the efficacy of tests that can be added during IVF, because it's the only way to eliminate any kind of selection bias, and also the only way to determine any positive and negative predictive values of specific results for specific outcomes. So in this study, they performed 484 single embryo transfers. And when they unblinded the PGT-A results, they found that of the embryos that they transferred, 312 of them were euploid and 102 of them were fully aneuploid. So right now we're not talking about mosaics, these were full aneuploides. And here's how those results matched up with the outcomes. 64.7% of the euploids resulted in live births, but not a single one of the aneuploids did. So 0 aneuploids resulted in a live birth. There were a few embryos with mosaic results in the study, but it was very small numbers. So there were 16 whole chromosome mosaics, which had a nearly 69% live birth rate, and 39 segmentals, but they didn't distinguish between mosaic segmental and non-mosaic segmental in this study, but those had about a 31% live birth rate. The authors do clearly state that the mosaicism and segmental data here can't be used to draw conclusions or calculate predictive values, since the study just wasn't adequately powered for this. But the data that it gave us about the whole chromosome aneuploids is extremely valuable. Another non-selection trial was also recently published. This one was by Antonio Capalbo and colleagues, and this one was powered to look at mosaics. So in this study, it wasn't the entire PGT-A result that was blinded, but instead what they did was they categorized results upfront as either euploid or aneuploid using a 50% cutoff. So any sample with less than 50% aneuploidy got diagnosed as euploid, and any sample with more than 50% aneuploidy got diagnosed as aneuploid. And then they transferred the euploids only. So they weren't assessing the outcomes of the aneuploid or the higher level mosaic group in the study. But after the outcomes were known, they unblinded the euploid result to see if any of those had an intermediate copy number. So if it was between 20 to 30%, they called that low level mosaic. If it was between 30 to 50%, they called that moderate mosaic. And any results that were below that 20%, they considered those true or uniform euploid. So this table shows the outcome of comparing the outcomes of those three groups. So group A is the full euploids under 20% mosaic. Group B, those low level mosaics between 20 to 30%, and group C, those moderate or medium grade mosaics between 30 to 50%. And what they found was that that there was no difference in live birth rates or miscarriage rates between those three groups. So overall, what they concluded was that mosaic aneuploidy levels under 50% don't have any impact on an embryo's reproductive potential and can be considered the same as euploid embryos. So how do we reconcile these different findings between the Viotti study and most studies out there that are finding poorer outcomes from mosaics compared to euploids, and the Capalbo study, which found that mosaics and euploids seem to be the same? Well, the Viotti study and most studies were retrospective, so patients had either transferred a euploid or a mosaic based on their particular clinical situation, and that introduced a selection bias because patients who transferred mosaics probably would have been more likely to have had past implantation failures or miscarriages with their euploids. They inherently had a poorer prognosis. But also, if we look at the pregnancy rates, in the Capalbo study, the pregnancy rate was much lower. It was kind of unusually low, particularly compared to the Viotti study, which already pregnancy rates for euploids was kind of on the lower side. And also remember that the Viotti study included all types of mosaics. So if we only pull out those low-level whole chromosome mosaics and we actually compare apples to apples, the pregnancy rates of those mosaics was actually about the same. It was 40% in the 1,000 mosaic embryo study and 42% in the non-selection study. So while the Viotti study did find a difference between euploids and mosaics, and the Capalbo study did not, the difference was actually in the pregnancy rates of the euploids. It was not in the mosaics. Other explanations, sort of hard to know. There were slightly different NGS platforms that were used. But overall, I think this shows that there's still some debate about whether certain types of mosaic results are truly different from euploid results in terms of their impact on an embryo's reproductive potential. So the last question to address is really the ultimate question, I think. We know that mosaic embryos can lead to viable pregnancies, but for most patients and providers, the question really is about the outcomes of those pregnancies. Are they chromosomally normal? Well, if we look at prenatal and postnatal data, the risks are pretty significant. We know that fetal mosaicism can result in chromosomal syndromes, or if there was a monosomy or trisomy rescue event, then it can result in UPD. Confined placental mosaicism, usually less concerning, but can still lead to increased risks of fetal growth restriction, demise, or maternal complications. And these usually are the risks that people think about when we talk about mosaic embryos, because for many years, this was really the only data that we had about mosaicism. But the clinical picture that we're seeing with preimplantation mosaicism has been very different. So this data here is from an abstract that we had last year at ASRM showing the results of prenatal diagnosis from pregnancies with mosaic embryos. So out of 43 karyotypes and 36 microarrays, the original mosaic finding wasn't confirmed in any cases. And I just looked at our data this morning for an update, and we actually now have data on 49 karyotypes and 42 microarrays. And again, no cases where that mosaic finding was confirmed. The orange bars here, that shows unrelated findings. So most of those were very small copy number variants that were below the resolution of PGTA. Most of them turned out to be inherited from one of the parents. So these would have been equally likely in a euploid embryo. They didn't have anything to do with the mosaicism, and they were on different chromosomes. So our conclusions were that the risks of chromosomal syndromes with mosaic embryos, or the risk of an adverse outcome, seems to be overestimated for the most part. The results from the non-selection study were similar. They found that 38 newborns from mosaic embryos that were able to be tested were euploid. They also went a step further and they genotyped those newborns and found that all of them showed genome-wide biparental inheritance and none of them had UPD. There have been several other published studies about live births from mosaic embryos, and although the sample sizes in each individual study have been small, and also defining the outcomes have varied from karyotypes of chorionic villi to karyotypes of amniocytes or microarray. Sometimes it was just routine physical exam of the newborn, but overall this outcome data definitely starts to add up, and what it's really showing is an absence of abnormal outcomes. In the 1,000 mosaic embryo study, we didn't include an analysis of karyotype or microarray results. That's something that's still in the works. But meanwhile, we did have an abstract at ASRM a couple of years ago that reported on length of gestation and birth weight from this cohort of patients. We compared 162 deliveries from mosaic embryos to 162 deliveries from euploid embryos. And each mosaic case was individually matched to a euploid control on the basis of oocyte age, patient's infertility diagnosis or reason for PGT-A, the embryo's morphology, and the day of biopsy. And we didn't find any significant differences in either length of gestation or birth weight among the babies delivered. Most of the literature on this topic cites a single case report of confirmation of a mosaic PGT-A result in the subsequent pregnancy. In this case, it was an embryo that was showing 35% mosaicism for monosomy 2 that was transferred, and the amnio showed 2% mosaicism for the reciprocal trisomy 2. The fetal anatomy seemed to be normal, and the couple had elected to continue the pregnancy. After delivery, blood karyotyping showed monosomy 2 in 2 out of 100 blood cells, and 400 buccal cells were normal. Unfortunately, the placenta wasn't able to be tested in this study, but the authors reported that there was no apparent phenotypic abnormality. Of course, we don't know if there could be any later impact from this. There is actually one other case that was documented that doesn't usually get mentioned because it was only sort of casually stated, and it wasn't even in the study itself. It was in an author correction to their previous publication. In the original paper, the authors reported on healthy babies that were born from what they referred to as aneuploid embryos, but all of them actually were mosaic or segmental aneuploid. In one case, they reported transfer of an embryo that was mosaic for a duplication on chromosome 10. And they reported that the resulting live birth, the baby had a normal karyotype. But later they issued a few corrections after a lot of these results were called into question. And for this case, they amended the baby's karyotype to a non-mosaic duplication on chromosome 10. It wasn't the exact same duplication, but it was in the same region, I think, close enough to consider that to be probably a confirmation of it. They reported that the baby was found to have coarctation of the aorta, but was otherwise healthy. Given that there were a lot of discrepancies in this paper, it's sort of hard to know how accurate this information is, but it does seem like this could be a second case of PGT-A mosaicism confirmation in a live birth. So what about specific chromosomes? How does that play into predicting clinical outcomes? In the early days of mosaic embryo transfers, there was a big rush towards putting out guidelines and recommendations about which embryos should and shouldn't be considered for transfer and how to prioritize or rank different mosaic results on the basis of chromosome number. But all of these lists were made solely based on prenatal and postnatal data because there wasn't any preimplantation data at the time. So we really need to recognize that since there are only 2 documented cases of abnormal outcomes, there really isn't any evidence to make these types of assessments. And some of these statements like PGDIS have been updated to no longer include these types of ranking lists for that very reason. So what is the data showing? Unfortunately, it's very limited because you can imagine how many embryos it takes to find enough that are mosaic for each individual chromosome number. So all of the outcome studies are just vastly underpowered to draw any kind of conclusions when it comes to specific chromosome results. Even in the 1,000 mosaic paper, that's the table here on the left, you can see how few embryos were in each category. Here's the monosomies for each chromosome, and here's the trisomies. So you can see a lot of them are just single-digit numbers. And then the ones that are highlighted are 13, 18, 21, and X, since those are of most interest to people. In the non-selection study here on the right, it was only whole chromosome mosaics that they were looking at. Here they had removed the segmental mosaics. So the sample sizes here are much larger, again, showing chromosomes 13, 18, and 21, but they don't distinguish between monosomy and trisomy. This includes both. Overall, though, the data seems to be pretty reassuring. If we add up all of the numbers for chromosomes 13, 18, and 21, it adds up to 152 embryos involving trisomy or monosomy of those 3 chromosomes, and none of them have led to an aneuploid ongoing pregnancy. Remember, though, that the non-selection study, this one here, was looking only at embryos with mosaicism under 50%, though, so the risks could be significantly higher with those showing a greater amount of mosaicism. We just don't really have the data there. But there is concern that a lot of those higher level mosaics might actually be false negatives of potentially full meiotic aneuploidies. So if you're potentially transferring a high level mosaic trisomy 21, it's possible that could be a misdiagnosis of a full trisomy 21. So I think, we need to be more cautious with those. So given all this data that we have, it seems pretty reasonable to conclude that prenatal and preimplantation mosaicism just can't be looked at through the exact same lens. They're diagnosed differently. Prenatal mosaicism is often directly visualized by seeing different karyotypes in different cell lines, while preimplantation mosaicism can at most be inferred based on an intermediate copy number. The chance of getting a mosaic result prenatally doesn't depend on who's doing the CVS or which lab it's being sent to. It's pretty stable. But for preimplantation mosaicism, it very much depends on the IVF clinic and the PGT lab. Prenatal mosaicism is obviously detected at a much later developmental stage, and prenatal mosaicism has known risks, which we're not seeing with preimplantation mosaicism. So combine these differences with the finding that IVF pregnancies have not shown to have increased rates of either fetal or confined placental mosaicism compared to non-IVF pregnancies. And there's just really no evidence at this point that a mosaic PGTA result increases those risks that we think about with prenatal mosaicism. So I would say if you remember only one thing from this talk, it should be that all the evidence we currently have about PGTA mosaicism is that it may impact early embryo development. But again, there's no evidence, at least at this time, of increased risks for ongoing pregnancies. So what's happening in practice when it comes to transferring mosaic embryos? In 2018, there was a survey of 252 IVF clinics around the country, and just over half stated that they would transfer a mosaic embryo. A couple of years later, Christina Wren addressed the same question as part of her larger grad thesis and found that the proportion increased to 70%, although the number of clinics in this study was a bit smaller. Among clinics that had specific policies about mosaic embryos in place, 39% of those policies were to not transfer mosaic embryos, and the providers cited liability concerns and the counseling burden associated with managing these transfers. Now, keep in mind that this data is from a couple of years ago, and a lot of what we covered today has been published since then, a lot of it even just in the last couple months or so. So I think it's very likely that we would see different results if these surveys were conducted today. Also, similarly, so in early 2018, our group had published about patient decisions regarding mosaic embryos. And at the time, we found that of all patients who only had mosaics, so these were patients who didn't have euploids, and they were counseled about the option to transfer their mosaics, 30% moved forward with transferring, while 42% chose to do another cycle instead. Again, this was before we had a lot of the outcome data that we have now, so I think these results would probably look pretty different today since the counseling was a whole lot more cautionary at that time. As far as guidance from professional societies, there's a 2017 statement from ASRM that addressed transferring embryos with what they refer to as genetic anomalies. Most of the statement was about the ethics of transferring embryos with positive single gene results, but they did lump mosaic embryos in, which now we know doesn't really make sense, but at the time, we didn't know, and those were lumped in. And overall, the conclusions were that providers can ethically assist or decline with such transfers. In 2020, the Genetic Counseling Professional Group of ASRM, I mentioned we published this practice committee opinion specific to mosaic embryo transfers. And this document reviews the data that we had at the time. The main purpose was really to outline the data as well as pre-test and post-test counseling points for providers. So while I'm thrilled that this statement was published as a resource for clinics grappling with mosaic results and embryo transfer decisions, it took such a long time to get this published that it already needs some major updates. So we're hoping to accomplish that at some point soon. So just to wrap up, we clearly know a lot more about mosaic PGTA results now than we did even a few years ago, but there's still quite a few lingering questions. How can we manage recommendations about mosaic results in an evidence-based manner? Should patients be counseled about prenatal diagnosis differently when they transfer a mosaic compared to when they transfer a euploid embryo or an untested embryo? Remember that ACOG recommends that all pregnant people be offered prenatal screening and diagnosis equally, and there doesn't seem to be any increased risk of abnormal results for those who conceive from mosaics, but in practice, it's hard not to be thinking more about recommending amnio for these cases. So we have to question whether the benefits of amnio outweigh the risks if the risks aren't truly increased. Also, what about the benefits of expensive add-on tests like microarray or in particular UPD testing, which isn't routinely offered? We also have to consider the psychological impact that all of this testing has on patients. And while the current guidelines state that providers can accept or decline to transfer mosaic embryos, can they still really ethically choose to decline given the data that we have today? Can they ethically recommend that the patient undergoes another expensive, physically and emotionally demanding IVF cycle to try to get a different embryo that may or may not have a better chance of success or may not have any different risks? And in cases where the data predicts a higher pregnancy rate for a mosaic embryo compared to a euploid because of the morphology, can we still justify transferring the euploid first, even though that feels more comfortable for everybody? And while most of the discussion is about whether we should transfer mosaic embryos, we also need to take a step back and consider whether mosaicism should even be reported, particularly types of mosaicism that have more consistently shown to have little or no impact, like segmental mosaicism. I'm sure many of us have seen the New York Times article last month about NIPT for microdeletions and the concerns that were raised about positive results having very low positive predictive values. For mosaicism, we don't even know the positive predictive values for various outcomes. And if we're looking specifically at the positive predictive values for an ongoing aneuploid pregnancy or for UPD, that seems to be pretty exceedingly low based on the data that we do have. Also, if we compare this situation to expanded carrier screening, typically variants of uncertain significance are not reported because they're not considered actionable. So does it make sense to report intermediate copy numbers, which implies inherently that this type of result is potentially risky without actually having that evidence? And the last question that I'm going to ask before I turn it over to additional questions is it ethical for labs to report mosaic results as aneuploid simply because the clinic doesn't want to deal with the confusion and counseling burden of these results? So thank you for listening, and I'll turn it over to Jessica to see if there's any questions.
Andrea, thank you so much. That was an amazing presentation, and we definitely have some questions, but I would encourage anyone who hasn't already gone ahead and put their question in the Q&A to go ahead and add it. We'll get through as many as possible. And I think Andrea has graciously agreed to offer up her email address in the chat as well, in case we don't get to all of these questions or others of you have questions after we sign off. So we'll get started. The first question, I think, is just a clarification question. Can you explain the segmental versus other mosaicism types again, please? So just maybe giving a quick clarification on that.
Yeah, so segmental mosaicism refers to if the embryo is found to be mosaic for a deletion or a duplication, or sometimes the lab reports it as a partial trisomy or a partial monosomy. So there's different ways the lab can report it, but it's to distinguish it from whole chromosome mosaicism, which would be mosaic for a full trisomy or a full monosomy.
Perfect, thanks. And then can you explain why the embryo may initially appear to be mosaic, then appear to be euploid when retested?
Yeah, so it could be because a big reason for that is because if the embryo truly is mosaic, there's going to be that mix of normal and abnormal cells there. And in that case, you might, in the first biopsy, grab some of those abnormal cells, but in the second biopsy, maybe you just don't. Or it could also be because maybe there never really was mosaicism. Maybe there was some sort of noise or artifact or contamination of the sample that first biopsy was just an incorrect result. But by definition, if we're assuming true mosaicism, then I think that is sort of the bigger explanation would be that the first biopsy shows some abnormal cells and the second biopsy just didn't happen to grab those.
And this is one that is near and dear to my heart, having come from the NIPT world. Any data about subsequent NIPT results for known mosaic embryos?
Not that I know of. That's something that, I hope that we have data on soon, because I think it would be really valuable to see, especially because NIPT is looking at placental DNA. I think one of the questions is, a lot of these patients are, if they do testing, a lot of them are doing amnios. So we're getting, that fetal results, but we don't really still know what's going on in the placenta. A lot of patients that are doing NIPT, another difficulty is a lot of them are just having sort of regular NIPT 13, 18, 21 X and Y ordered, when that's usually not the result of the mosaic embryo, because I think a lot of providers are sort of staying away from 13, 18, 21 X and Y for mosaic embryos. So if the patient's transferring a mosaic trisomy 3, their OB orders NIPT for 13, 18, 21, we're not actually even getting any kind of data on it. So even though there are a lot of patients that do NIPT afterwards, it's not, it's not giving us the information that we need.
For sure, that makes a lot of sense. Next one is, are there any longer follow-up studies of children looking at overall development in live births of mosaic embryos? So maybe longitudinal studies or anything that may be ongoing.
Not that I know of. So we are trying to, this is, I guess, a little bit different because it hasn't fully been fleshed out, but there has been some discussion of having some sort of registry of transfers, because it's difficult, waiting on various clinics and labs to kind of publish their small sample sizes here and there. And what would be beneficial to everybody, I think, would be to have some sort of larger registry that clinics can contribute to sort of build up those numbers, and potentially having a way to maybe track longer outcomes. But as far as I know, all of the outcome data has been from prenatal testing or right at birth or shortly after, nothing longer term.
Something to look forward to in the future, hopefully. This is more of a comment, but I think it'd be interesting to hear your take on it. I'd be interested in seeing if there is an association with clinics that transfer mosaic embryos and those that employ or have access to a genetic counselor. I would think that would help solve some of the concern regarding counseling burden. So don't know your take on that, but what would the association be, or is there an association between those clinics that are more likely to transfer mosaic embryos and those that have genetic counseling services?
Yeah, that's a good question. I mean, I would imagine, I don't know the answer, but I would imagine that clinics that have genetic counselors are just more likely to be transferring mosaic embryos. Like, I was hired into my position specifically because of mosaicism. Obviously, it's not, the only thing that I do in an IVF clinic, but that was really what prompted my clinic to realize, we can't really do this alone. We really need a GC to be helping us with this. So I would definitely imagine that clinics that have GCs are at least more able and willing to sort of have that conversation and make a policy that's based on the data that's out there. Because I think, a lot of the REIs out there just don't really know how to handle this so well.
For sure. And this is kind of an extension, I think, of that a little bit. So are you aware of any clinics or studies looking at the ethics of choosing not to transfer mosaic embryos and not accepting a transfer? And any clinics nationally that are open to taking on patients who had cycles and biopsies elsewhere?
Sorry, can you say that again?
Sure. Are you aware of any clinics or studies looking at the ethics of this? So potentially not agreeing to transfer a mosaic embryo, and any clinics nationally that would be open to taking on patients who had cycles and biopsies elsewhere that maybe their home clinic isn't willing to transfer a mosaic embryo?
Yeah, so as far as I think there have been a lot of commentaries about the ethics of it. I don't know about any sort of formal studies kind of analyzing the issue. Personally, I think it's kind of hard to make a case for not transferring mosaic embryos at this point. I think 5 years ago, my answer to that would have been completely different. But I think now that we have this data, I think it is harder to make a case. As far as other clinics that can take these patients, it is more limited, because I know that there are several clinics, including mine at NYU, where we will absolutely transfer mosaic embryos that are created in our clinic, but we don't actually accept embryos from other clinics. We overall just kind of accept a limited number of outside embryos in general, but we specifically won't accept embryos from other clinics, only because we really didn't want that to become, our thing, that we were having patients coming to us only for that reason and bringing in all of the mosaics, especially a few years ago when we were one of the only clinics that was doing it. So I think sometimes these patients do have a hard time finding a clinic that will take in their embryos. So I think the most important is that patients discuss with their provider before they do a cycle, what's going to happen to those embryos? Will they have the option to transfer? Because if the provider tells them right up front, which they really should be doing, that if we get these mosaic results, you're not going to be able to transfer them, it's much easier to give them the option of going somewhere else in the first place to do their cycle versus then moving their embryos later on. But there are some clinics that will accept mosaic and even abnormal embryos for transfer from other clinics.
Just wanted to give you the shout out that this is one of the best presentations in history. That was put in the Q&A, so I agree. Continuing on with the questions, any insight on how to consider a no result embryo versus an embryo with a mosaic result? And does your clinic have an approach to that?
Yeah, I would consider a no result embryo as an untested embryo, as if it hasn't been through PGTA. I mean, sometimes the lab might be able to give a little bit more insight into why it's inconclusive, or they might even be able to give a little bit of behind the scenes of, well, we actually think it's normal, but it didn't meet our QA standards, so we couldn't call it. So some labs might be willing to do that. Sometimes it might be no result because there was just no DNA amplification whatsoever, and then nobody can predict. They just get no DNA. So I would probably first contact the lab to see if they have any insight about it. Sometimes it'll say directly on the report, no DNA found or no DNA amplification. And then you kind of already know the answer. But if it says something like poor quality DNA or contamination, the lab might have more insight. If not, I would consider it the same as an untested embryo, and I would quote risks just based on the age of the egg.
And in regards to the reproductive potential of segmental abnormalities, does the size of the deletion or duplication seem to have an impact?
I think there's not enough data yet because, well, with the segmental mosaics, there probably is, there's quite a bit of data on transfers of segmental mosaics. I don't think that there's enough to sort of, and I don't know if anybody's done this, looked at the size of it and if there is a difference in the outcomes. With segmental aneuploids, where they're not mosaic, but there's still a segmental abnormality involved, there have been so few embryo transfers reported with those altogether that there's definitely not enough there. But it's a good question. I think, I sort of think of it from two different perspectives, and it's definitely just sort of a hypothesis on my end, that the ones with the smaller deletions or duplications maybe are more likely to be artifact or noise, and maybe those would have a better chance if that's the reason for it. But I think overall, because some of these segmental mosaics really are mosaic, it's not an incorrect result. It's just that it's only in the trophectoderm. If that's the case, then there probably wouldn't be any impact on the size, but there really aren't any studies. We don't know yet, at least as far as I'm aware.
And based on your experience, would you suggest different prenatal testing recommendations following mosaic embryo transfer? So something like UPD studies, for example.
That's a tough one because I don't think the data justifies it, but at the same time, we want to use our intuition as well. So I think for me, if it's a monosomy or a trisomy 15, for example, I would offer UPD studies to the patient with the understanding that, this might be overkill. This might be spending your money and, ordering this potentially expensive test and making you wait longer for results when the chances of it actually being abnormal are probably very, very low just because of, the chance of UPD just in the general population. And we don't know if it's any higher with a mosaic embryo. But at the same time, we don't want to miss anything. So it's sort of a careful balance. I wouldn't recommend UPD for a chromosome that we don't have any known UPD syndromes for. I think, some providers do think of that because the thought is if they find UPD, maybe trying to figure out if, looking at the patient's carrier screening results and seeing if any of them carry something that's on that chromosome. And are we then worried about expression of a recessive disease? It's a little bit far-fetched, not that it can't happen though. So it's hard to say. I think there's a fine balance there, but, I would say for the most part, the data is not showing a need to do UPD testing.
Okay, and is mitotic self-correction another possible explanation for embryos that initially tested mosaic but later tested normal? this asker said, I believe I read that this has been observed in mice embryos.
Yeah, definitely. If the embryo is truly mosaic to start off with, it's very possible that those aneuploid cells that are there could just, undergo apoptosis, and it's the normal cells that might sort of take over during development. That's definitely one possible explanation. I think it's been shown that for whole chromosome, non-mosaic aneuploids, so fully abnormal embryos, the chance of that happening is really, really unlikely because those are largely meiotic errors. But if we were able to distinguish between meiotic and mitotic errors, that definitely could be a possibility for the mitotic ones.
And then I'm going to take a little liberty here and combine two questions because I think they're getting at the same thing. Can you comment on the complexity of explaining these results to patients? What is their understanding and the level of anxiety that they experience? So really, do they understand the science behind this, and how are they processing that?
Yeah, I would largely say no, they don't understand it. It's rough. I think every time I think a patient understands it, then they schedule another call with me and I realize, no, that they either forgot everything or, maybe they didn't actually understand it. So I think it's a hard concept to grasp that even when they do understand it on the spot, I think it's easy to forget all of the details of it and kind of become jumbled in their mind. And also, Google doesn't help. I had a patient who was scheduled for a mosaic embryo transfer today, and yesterday called me absolutely frantic that she, for the first time, decided to Google it and started reading about a deletion on that particular chromosome of the embryo that she was going to transfer. And she's reading about all these babies that have it. And of course, it sounds horrible. So, I had to remind her, okay, yes, that's what would happen if the baby were mosaic. If you were to do an amnio and you were to find that deletion was there on amnio, then yes, this might be what we would expect for a live birth. But the chances of that happening, of that mosaic embryo actually translating into that mosaic baby or the baby with that deletion, that's what's really low. And I think that's what's really, really hard for patients to grasp, because if you Google it or you read anything, you're always going to be reading about that prenatal and postnatal data. And we have to sort of remind people all the time that the preimplantation data is different, at least, from what we can see today. So I think it's really, really tough to explain this to patients. I think, especially because if you sort of try to summarize it in the least amount of detail as possible, what you're really going with is this embryo might be healthy or it might not be healthy. And when you think about it, that's the same as a euploid embryo. That's the same as an untested embryo or any pregnancy out there. So it's kind of hard to figure out just how much information to go into and what's going to actually be helpful, what is more for our purposes that we want to make sure that patients understand, because, we want them to understand what exactly mosaic means, but the patient only wants to know about what's this going to mean for my baby. So sort of trying to kind of reconcile those two things and not be too overwhelming. I think there was a second part to your question that I forgot.
No, I think you got it, actually. It was more just about the level of patient understanding that we can expect given this complex topic. So and that kind of leads us to, I think, what will be our last question, which is, does it seem premature to be so reassuring about mosaic embryos when there are no long-term studies and mosaicism cannot be ruled out either prenatally or postnatally?
I think there's two ways to look at it. The way that I look at things is innocence until proven guilty. Why are we suddenly calling out these results? And I think the way this whole thing started was that labs started off by reporting mosaicism. So it wasn't an understanding of embryo mosaicism leading to a decision to report it. The way that this all happened was labs decided to report it first. And now we're sort of backpedaling and trying to figure out what it means. But normally we do things the other way. So one thing that, this has been compared to before is, let's say, poor morphology embryos that get biopsied on day 7. Those are embryos that, nobody has really thought twice about transferring, because the thought is, well, maybe we biopsy them, maybe we don't, because they're poorer quality in the sense that maybe it's going to have a low chance of implantation. So is there a purpose to including this embryo? Should the patient be paying to biopsy and freeze it if it's only going to have a small chance of working? But nobody's ever said, well, day 7 embryos, nobody has proven that adults from day 7 embryos are healthy. We just say, well, there's there's never been any question, there's never been any evidence of a day 7 embryo being risky. And I would think of it the same as a mosaic. You know, there's no evidence that there's any increased risk. And now we're sort of backpedaling to try to find that evidence. But it all kind of happened backwards. But although you can think about it the other way, you know, and that is really what I say to patients when we talk about those potential long-term risks, when they're asking about that. I say you can either go with innocent until proven guilty, and that's sort of the way that I think about it. But some people feel, you know, I need proof of innocence. I need proof that these are not going to be an increased risk, and that's something we don't have. So if someone's not comfortable lacking that data, you know, that's reasonable as well.
Thank you, Andrea. This was really a wonderful presentation. Andrea has graciously put her email address in the chat for anyone who had additional questions we weren't able to get to. And we thank everyone for your participation today. Have a great afternoon.
Thank you.